Om Swastiastu. Hello, Dr. and friends. We are from SGD B1. We'll present our student project with the title Pulmonary TB in Children. This is a member of SGD B1. Thank you for the opportunity. My name is Gusti Agung Saraswati. My last studies number 056. Now I will explain about background. Pulmonary tuberculosis in children is infection disease caused by the bacterium Mycobacterium tuberculosis. Transmission generally occurs from adult infection with active TB. These lesions are usually gone complex, which can cause inflammation and calcification of the lungs. Prevention of transmission of TB infection also need to be improved with BCG vaccination and screening for TB case in adult around children. That's all from me. Thank you.
Hello, Dr. and friends. My name is Geraldine with the last three digits of student ID 100, and I'm going to elaborate the definition of tuberculosis. So, tuberculosis, or TB, is a highly communicable disease caused by Mycobacterium tuberculosis bacteria, which mainly affect the lungs, or we can call it pulmonary TB. But Mycobacterium tuberculosis can also affect other organ system in human body, or we can call it extrapulmonary TB. TB in children or pediatric TB itself can be defined as TB infection in children below 15 years of age. That's all from me. Thank you.
Hello, my name is Pande Putu Candra with my last student name R240. And now I'll present you about the etiology. So TB is caused by the bacterium Mycobacterium tuberculosis. The bacteria are spread through the air when an infected person coughs, sneezes, or talks. When a child inhales the bacteria, they can settle in the lungs and cause an infection. The bacteria can also spread to the other parts of the body, such as lymph nodes, bones, and brains. Thank you.
Greetings, my name is Karuniaputri with students number 235, and this time I will start a topic called as pathophysiology of pulmonary TB in children. The disease course of pulmonary TB can be divided into four parts. The first one is immediate clearance from the organism, onset of active disease, latent infection, and the last one is active disease many years later, or called as reactivation phase. In the first phase, it's really determined by the effectiveness of an individual innate immunity. When bacteria enters the body, it will respond as an innate immunity, followed by an influx such as neutrophils macrophages. But when it's become insufficient, it will cause adaptive immune to be released by the body. Inadequate immunity will lead to more bacteriolysis, which cause the TB become an active disease or primary disease. The second one is primary TB, located in the middle portion of the lungs of the called as Ghon focus, named after Anton Ghon, an Austrian pathologist. The main difference that found in adult and children that is much less contagious in children rather than adult. The main symptoms in children mostly found in enlargement of the lymph nodes that will cause a small airways to obstruct, fever, and others. The timing where the symptoms are released by the body as the response to the infection is where the primary diseases happen. That's it from me. For the two other space of pathophysiology will be taught by my friends. Thank you.
Hello everyone, my name is Erick Gonata with 3 digit of my student ID is 086. So I will continue the presentation about the pathophysiology. The third phase of the pathophysiology is the LTBI or the latent tuberculosis infection. So the WHO defines that LTBI as a condition of persistent immunological response to stimulation by M tuberculosis antigen without any indication of clinically manifested active TB. To put it simply, LTBI is an infection with living MTB complex bacilli but without any signs of the disease. Since a sizable fraction of those who have LTBI go on to acquire active TB, which help the disease spread and remain in the community. LTBI is extremely important for the public health. In this phase, the formation of granuloma build a wall for the tubercle bacilli and limit it from the rest of the tissue, as well as limiting it from spreading and act as an immune microenvironment that prevent its replication. The fourth phase of the pathophysiology is dereactivation or deactivation after many years. This phase is most likely begin with the functional disruption of the granuloma, which leads to the reactivation of latent MTB. So at the third phase, we have the wall surrounding the MTB, and the reactivation begin with the functional break of the wall. That's all from me. The presentation will be continued by my colleague. Thank you.
Hello, my name is David Christopher Chandra with the name 066. I would like to continue about the signs and symptoms of this disease. So the next one is lymphadenopathy, a condition where lymph nodes become swollen and enlarged. So in this case, Mycobacterium tuberculosis spread through the lymphatic system and form granulomas in the lymph nodes. Children with developing immune systems are more susceptible as they result in a more significant response to infection. Children displaying vague symptoms, including low-grade fever, night sweats, weight loss, and a persistent cough, may indicate an insidious presentation. And the next one is hemoptysis, where there is the appearance of blood in the sputum or coughing up blood. It occurs from the ruptured aneurysm that enters the cavity, and it is the result of cavitary infection that invades the adventitia and media of bronchial arteries and leads to vessel wall swelling. And children with pulmonary TB experience hemoptysis because of the erosion of the bronchial artery, or we know as bronchiectasis, or scientifically known as Rasmussen aneurysm. Then the next one is the night sweat or nocturnal hyperhidrosis. It is a condition where there is an excessive activation of the body's sympathetic nervous system, which is responsible for increasing heart rate, dilating pupils, and night sweats. As immune system cells respond to the infectious exposure, they produce signaling molecules that cause night sweats in children with pulmonary TB. The hypothalamus temporarily increases body temperature in response to these circulating chemical signals. And when the body temperature returns back to normal, the additional heat is expelled through the sweat.
Next, I will explain about signs and symptoms. But before that, let me introduce myself. My name is Putu Indriati with last digit number 231. Pulmonary tuberculosis or TB in children presents some signs and symptoms. There are cough, weight loss, fever, asthenia, lymphadenopathy, hemoptysis, and night sweat. First, cough. One of the hallmark symptoms of pediatric pulmonary TB is a persistent cough. Fever. Fever is another common sign in pediatric pulmonary TB case. However, unlike many other childhood illness, where fever is often an early and prominent feature, TB-related fever tends to be more intermittent and may present as low-grade or even periodic spikes. Weight loss. Unintentional weight loss is another potential sign of pediatric pulmonary TB. Asthenia. Asthenia, which refers to weakness and fatigue, is another subtle but important symptoms in pediatric tuberculosis.
Thank you for the opportunity. My name is Geg Mas Anantalakshmi with the last digit of NIM number 001. Today, I will explain the diagnosis of tuberculosis. Mycobacterial culture is the gold standard diagnosis method for TB, but it takes a long time, often weeks. It is necessary for phenotypic drug susceptibility testing. Smear microscopy is a low-cost and practical way to test for TB. However, its sensitivity ranges from 20% to 80%, and it's not very specific. Rapid diagnosis tests, expert MTB/RIT, detects TB and rifampicin resistance in suspected case. Expert testing can diagnose faster while awaiting culture testing, or in the absence of culture testing. The next topic will be explained by my colleague.
My name is Zephania Ekklesia and my student ID number is 127. Now I'm going to be explaining about the diagnosis of pulmonary TB. Clinical evidence found by history taking and physical examinations, which includes fever, weight loss, loss of appetite, persistent cough, lymphadenopathy, are the clinical manifestations of TB. While in some LTBI cases, the most cases are asymptomatic. The second one is radiographic imaging. Parenchymal pulmonary lesion, known as cone lesion, that may affect surrounding lymph nodes, forming cone complex as a hallmark of TB. The next one is tuberculin skin test, which measures the type 4 hypersensitivity reaction of host immune system after M. tuberculosis exposure. It is also important to note that this test cannot distinguish between LTBI and active TB infection.
Hello, my name is Sabrina and I will continue the explanation. It's about differential diagnosis. One of the differential diagnoses for pulmonary TB disease in children is idiopathic pulmonary hemosiderosis. Idiopathic pulmonary hemosiderosis, or IPH, is a rare disease characterized by repeated episodes of diffuse ocular hemorrhage, which over time can lead to a variety of respiratory complications and permanent lung damage. Pulmonary hemosiderosis is usually divided into three types based on the characteristics of the disease. Group 1 pulmonary hemosiderosis is defined by pulmonary hemorrhage associated with circulating antiglomerular basement membrane or anti-GBM antibodies. Group 2 pulmonary hemosiderosis is defined by pulmonary hemorrhage accompanied by immune complex disease. And Group T pulmonary hemosiderosis is defined as pulmonary hemorrhage with no known immunological association, also known as idiopathic pulmonary hemosiderosis or IPH.
Hi, my name is Caitlin. My last three-digit number is 138. I'm going to explain about the complications. First, there is increased oxidative stress. During the initial phase of the infection, the host produces a lot of ROS that is initiated by the inflamed cells and decreases the production of glutathione that can impact the control of the disease. Some studies have shown that glutathione has influence to lower the overexpression of pro-inflammatory cytokines. On the other hand, it also contributes to bacterial survival. So, by decreasing the production level, the survival level of the bacteria is higher. Second, there is hematological manifestations. The most prevalent kind of anemia in all TB subtypes is reported to be normocytic normochromic anemia that causes prevention of iron transfer to the nucleus of erythrocytes by the reticuloendothelial. On the other hand, macrocytic anemia brought on by a lack of folate and vitamin B12 may arise as a result of inadequate dietary intake or as a result of increased bacterial throughout an active illness. And the third complication, we have bronchiectasis, where the tissue breakdown and chronic fibrosis in TB can result in bronchiectasis or a permanent enlargement of parts of the airways of the lung. Next on, we have pleural disease, a direct spread from a caseating subpleural focus or hematogenous spread could be the mechanisms of pleural disease that is more common in older children. For example, an obstruction of lymphatic drainage could cause a pleural effusion. And last but not least, pericardial disease that would be shown with pericardial thickening with or without an effusion on the imaging result could be caused by the erosion of lymph nodes into the pericardium that can lead to pericarditis. That's all from me. Thank you.
Hello everyone, my name is Natania Sutedja with release digit of student number 175 and I'm gonna explain about the management of tuberculosis in children. The standard first-line treatment of pulmonary tuberculosis is isoniazid, rifampin, pyrazinamide, and EMB. The goal of this treatment for this first one is to cure tuberculosis in short-term and long-term cause and protect the individual from acquired resistance. In drug-susceptible cases, isoniazid and rifampin can be continued up to 4 to 6 months for complete treatment. In isoniazid resistant or intolerance, isoniazid can be replaced with fluoroquinolone, and in multi-drug resistant cases, empiric treatment can be used with 4 to 6 active drugs with prolonged duration, typically between 18 to 24 months. The WHO recommendation for rifampin-resistant children is bedaquiline in shorter and oral regimen and in longer regimen with the dose being modified depending on the weight and age of the children. In children under 3 years old, it is recommended to use Delamanid due to the safety and tolerability of the drug. That's all from me. Thank you very much.
So this is our conclusion. TB is highly communicable disease caused by Mycobacterium tuberculosis, and TB in children itself can be defined as TB infection in children below 15 years of age, and basically the children got pulmonary TB due to risk factors such as living with people with TB or having HIV. The hallmark symptoms of pediatric pulmonary TB is a persistent cough and lymphadenopathy. Clinical manifestations and CT imaging can be used to make TB diagnosis, and TB in children should be differentiated from idiopathic pulmonary hemosiderosis, and several conditions can be found in TB patients such as increased oxidative stress, hematological manifestations, bronchiectasis, pleural disease, and pericardial disease. The standard first-line treatment of pulmonary TB is isoniazid, rifampicin, pyrazinamide, and EMB. The goal of this treatment is to cure tuberculosis and protect the individual from acquired resistance. And the last, we advise you, the readers, to maintain the health of themselves and others, and spread knowledge to the closest community to avoid all forms of disease, including TB, especially in children. We also suggest that readers use this paper to initiate other research on TB in children to help our society become healthier and our doctors become more knowledgeable. This is the last part of our presentation. That's all from us. Thank you.